Just got a notification. So yes, hi everybody. My name is Katie. I'm the clinic director at the Surrey Park Clinic. It is an absolute honour to be here this evening and to have been contacted by Victoria. Obviously, Alex is our menopause specialist at the clinic. And for any kind of further information on appointments or anything at all, after this session, do obviously feel free to contact the clinic directly. You can go to the website, you can fill in some contact forms or give us a ring tomorrow. But yeah, I will hand the floor over to Alex.
Hey, hi everybody. My name's Alex Standring. I'm a GP locally, and I've been working at Surrey Park for I can't remember how many years, but quite a few. So this is really going to be very informal. I'm not a lecturer with slides and things like that. I did an Instagram live recently that was a sort of Q&A type thing, which we thought worked quite well. So I'm very happy at any point to answer questions. I apologize if I lose my flow if I do that a bit, but I thought that I would sort of basically run this a bit how I just do my clinic appointments really. Obviously I'll discuss the symptoms and diagnosis and stuff first, but then after that I have a spiel which I have to go through, and if I stop I forget halfway, so I might sound a bit blurby, but as I said, feel free to ask any questions, and I'll be quite sort of basic, as I said, to start with, and then we can go on from there if that works quite well. So I'm sure most people are aware of the main symptoms of the menopause, which are the poor sleep, hot flushes and night sweats, and irritability and moodiness really. And I think even most men know about that, but there are a lot more that you might not be quite so aware of. And one of the big things that I see is this sort of brain fog really, where really quite high powered women just lose the ability to think clearly. You lose your memory, you get very anxious, or you can get very anxious, and a lot of people say that waiting outside a business meeting and just having a massive panic attack, and it's just never happened before. And so that's a really big thing that people struggle with. You can get a lot of sort of joint aches and pains, and it's difficult, isn't it, because we all think we ache when we get older, but actually there's a lot of evidence that we have estrogen receptors everywhere in our body, particularly in our joints and our cartilage and things and our muscles, and so you get a lot of aches and pains with that. And actually a lot of people I see are really quite fit and want to be active, and there's quite a good evidence that if you even if you exercise after the menopause, you will still lose 2% of your body mass every year, which I think is really shocking, and that's because of lack of estrogen receptors. So so that's a big thing. Obviously we get the skin symptoms and the baggy face and dry skin, and that can affect your eyes. Lots of people get really dry eyes around the time of the menopause. And obviously the other big place is vagina, which is a massive problem for people. And it's not just vaginal dryness, which has all the sort of knock-on effects of that, particularly relationship wise, but you also and can get a lot of bladder irritability. So not only are you waking up because you're hot and sweaty, you then have to go to the loo in the night, and then as you get much older you've got osteoporosis and you fall over and you break your hip. So the whole thing can be a bit of a nightmare, and actually very easily treated with some, or often quite easily treated with some estrogen. So those are the sort of big things that people complain about. There are loads of other little symptoms which I'm sure you've seen if you've looked into it at all, like sort of itchy skin and ants crawling and achy legs and restless legs and all those sorts of things, but they're probably the main things that I see from a symptom point of view. And generally the average age in the UK is about 52 when it tends to happen. So obviously there's a big spread. Some people in their early 40s and some people in their late 50s, early 60s are still having symptoms at that point. And it can go on. I've got lots of patients in their sort of 70s and 80s who still have hot flushes if they stop their HRT. And it's not, you don't just get a rebound when you stop it. It's just that they just never stop. So I have a lot of quality of life discussions with patients about, risks and benefits, which I'll come on to. And generally, we don't do blood tests to diagnose it if you're around the right sort of age, because by definition, if you've got symptoms, you're, and you're of a right sort of an age, you're going to be menopausal. But the blood tests have become quite useful. Obviously, we have the benefit of the private clinic. It's, we can do those easily. It's not so easy to do on the National Health because, GPs have a budget, and I don't think many of them are particularly familiar with it. But, when you're trying to monitor treatment and things aren't going quite to plan, it's really useful to do bloods at that point. That's kind of the sort of initial bit, I guess, really. And the risks and benefits are the, that's always the big conversation. And I tend to start with the benefits because I think there are a lot more than risks. So, long-term benefits, if you start HRT around the time of your menopause, or even within the first 10 years, there's really good evidence that actually protects us against heart disease. Before the menopause, men have a much higher risk of heart attacks and things than women do. But after the menopause, we catch up. And in fact, cardiovascular disease is the biggest killer of women. It's the number one. But we all worry about, well, most people I see worry about breast cancer, but that's number 8. It's right down at the bottom. So, so cardiovascular disease is a big thing. Starting it early, really good evidence that protects you going forward. And the other really big thing with brilliant evidence for it for HRT is osteoporosis. And there isn't really anything better for your bones than estrogen going forward. I mean, obviously exercise and not smoking and being of a reasonable weight, and weight-bearing exercise, not just swimming, all very good for osteoporosis too. But being on estrogen is better than anything. And then obviously you've got all the sort of the sort of symptomatic-y things, like it stops your hot flushes, it helps you sleep better, helps with your vaginal dryness, often helps with your libido too. And whether that's just because you feel better, that you're actually a bit more interested in it and you're not exhausted, or whether it's just that it just works as well. Your skin's better, obviously the joints, aches and pains. Lots of people who suffer with migraines and things tend to get much worse around the time of the menopause, and then it can be a bit more tricky to treat those, but that generally feel very much better, and lots of people really benefit from going on HRT for that. So what other benefits are there? They're the main things. I'll probably think of some more as I'm going along. And then obviously the biggest risk is breast cancer. And if you're on combined estrogen, if you have a womb, you need estrogen and progesterone. There's lots of different evidence around, and I don't tend to quote numbers because I think it depends which report you read and who's twisted it around the way they want to, really. So basically, I think you have to accept that if you're on HRT for probably more than 5 years, there is going to be an increased risk of breast cancer. But it's about the same as other sort of lifestyle risks, such as if you were a smoker, if you're very overweight, if you've been on the pill, if you drink too much, if you drink 2 units of alcohol a night, that is a similar sort of risk of breast cancer increase. And as I said, breast cancer is the 8th biggest killer of women. And if you're on HRT and you get breast cancer, you're actually no more likely to die from it than somebody who's not on HRT. So you are more likely to get it. And obviously it's a horrible thing. And I know many of you work at St. Luke's, and you wouldn't in any way wish it on anybody, but the mortality from it isn't raised. So that's quite a big thing. And you have to weigh up your own your family history, your personal history, your risk benefit, and come out at the end of it and make a decision according to that. But that really is the biggest con, really, or the risk for it. You possibly stroke if you're older and have any other risk factors. There's a bit, the jury's out a little bit on that, but it might be raised by HRT. But generally with transdermal estrogen, as in through the skin, your risks of cardiovascular disease and having blood clots and thrombosis and things are not raised at all. So and it probably reduces our risk of Alzheimer's, reduces the risk of bowel cancer, and generally you just feel better and more able to cope with life, and your marriage is likely to last longer, and your children love you again. So I think there's so many benefits. The treatment wise, I'll just do that quickly. I mean, as I said, I'm doing it all fairly briefly, but if you from a menopause point of view, most of the people I see have probably been through all the herbal and healthy or non-medical alternatives. You can take black clover and red cohosh. Some people find Oh, my brain's gone now. Oh gosh, never mind. I'll come back to it. St. John's Wort can help with the mood, and there are other things that you can take for hot flushes. But generally, by the time I see people, they've often tried those things, phytoestrogens and soya, but they're all fairly similar to estrogen. So if you've had things like breast cancer, you shouldn't really take any of those herbal remedies. And people think because they're herbal, they must be, healthy and safe. But actually, there's not really as much evidence for those as there is for, well, there's very little evidence and very little trial data. So actually, at least we know what we're getting with HRT, and we know it's going to do what we want it to do from the benefits point of view, aside from just the symptomatic side of things. So yeah, so that was where was I've gone off. I go off on a tangent, sorry. What am I doing? I've gone blank. Where was I?
What you can take and what you...
Yes, herbal stuff. Sorry, yes. Anyway, yes. So I need another patch. Sorry, I'm running a bit low. Anyway, so from a treatment point of view, you need the estrogen. That's what makes you feel better. That's what generally sorts out your hot flushes and your night sweats and your sleep, which is most people have those symptoms. And that's what gives you the benefits for your cardiovascular disease, your bone protection, your bladder irritability. All those things are improved by estrogen. And most people, breast cancer aside, really can take transdermal estrogen. There's not many cases that you can't have it, or some liver disease and things like that, but very few really. And the best way to, well, there's the two main ways of having it are either as a patch which you put on and you change twice a week, or as a gel that you put on every night or every morning, doesn't really matter which. And that's transdermal estrogen, so it avoids going through the liver. If you've got problems with blood pressure or had blood clots or any of those sorts of things, it's absolutely fine and you can take it. And then you also need, if you've got a womb, you need progesterone, and that is to protect the lining of the womb, because if you have estrogen on its own, it can overstimulate the lining of the womb, and ultimately some people can get a womb cancer from that. So yeah, it's quite rare, but you still have to be very careful about that. And the kind of gold standard way of having your progesterone is a Mirena coil, and that is, used to be just used for contraception, but now we use it a lot for menopause, and it'll last for 5 years, and you can then fiddle around with your estrogen pretty much as you like, and you know that the womb is being protected. And there's little systemic absorption of the progesterone. I'll come on to the breast cancer a bit afterwards, but the Mirena, there is some absorption locally, but not as much. If you don't want a Mirena coil, which a lot of people don't, because by the time you've got to the menopause, you've generally had enough of that sort of fiddling around and things. And if you've got one, it's brilliant. But if you haven't had one, then, a lot of ladies don't want to go down that route, even though it is very good. So the next best thing, or equally good, possibly, is Utrogestan, which is the one that Davina's talked about a lot. That's micronized progesterone. It's body identical, as is the estradiol in the transdermal preparations. So it means it's the same we have in our body. It's really very friendly progesterone. It's brilliant. It helps you sleep and it helps your anxiety. So that's really good. Take it at night. So that's a double effect. It's not what we use it for, but it has this extra benefit. It's also very lipid friendly, so some of the old-fashioned progesterones can change your blood lipids and your cholesterol a little bit, whereas this has a very nice effect on that. And there is some evidence coming out now that it might be better on a breast cancer. I mean, I would never sort of sell it like that, but actually there's some studies being done that's showing it possibly has a reduced risk of breast cancer compared with some of the other progesterones, or even possibly neutral. But as I said, I think you have to just weigh that up, really. So that's the best way, ideal way. That's generally what I start most people on. Obviously, there's pills that you can take, and you, as I said, you can have estrogen vaginally, but that's not quite the same. That's just more for local symptoms. So if for any reason you didn't want to have systemic HRT, then you can have vaginal estrogen, which helps just for the vaginal symptoms and the bladder irritability and dryness and things like that. Some people need both patches and the vaginal estrogen. It just depends how you respond to each individual responds differently. So they're the two main ones. I also use quite a lot of testosterone. when people's levels of estrogen levels are topped up, sometimes the libido doesn't come back, and testosterone has been proved to have quite beneficial effects on that. Particularly, a lot of women struggle to have orgasms at that point, and if you have testosterone, there is some evidence that'll give you 2 satisfactory sexual experiences a month more than you would have done, which is quite a lot in my book. But some people say it's a lot better than that. And some people find it doesn't work at all, but you would generally have a trial of about 3 months and see how you feel at that point. It's not the problem we have in England is it's not licensed in women. It's only a preparation for men. It comes in various pumps and packages and stuff. So people sometimes are a bit reluctant to take it, but it's used a lot in the menopause world. There's lots of good leaflets that we can give people if they want to see, if they're a bit cautious about taking it. And there generally aren't, massive side effects, and they do reverse if you get any. The main one is people tend to get sort of slightly hairy legs, or increased facial hair. You can get some spots and things like that too. Possibly a bit of loss of your hair on your head, but if you do get those side effects, it's generally it settles down if you tweak the dose. And actually, a lot of my patients feel so much better on it. They say they're prepared to cope with the hairy legs just because they have generally much better. And also, some people, even though there's no kind of sort of not good scientific evidence, a lot of people just feel more energetic, and some people sleep better. So lots of people love it, and some people find it doesn't do anything, in which case there's no point in using it. But it's always an extra thing to try, and that does require a bit of blood test. That's the only other time that I do blood tests, is you have to do one before you start, and then you monitor it with some bloods. So that's the sort of main kind of general introduction, I guess, very quickly. But from a breast cancer point of view, obviously I know you a lot of you are at St Luke's. There are a lot of other options you can do. So, or if for any reason you didn't want to take HRT, obviously exercise is one of the best things that you can do. Keeping your weight down really helps with hot flushes. For the people who are sometimes the treatment for breast cancer, as I'm sure you know, I don't mean to teach you to suck eggs, but causes the symptoms to be worse. You get more vasomotor symptoms, more sweats, more hot flushes. Some of them give you some really horrendous joint aches and pains. Some patients find that actually, if you're one of the treatments for breast cancer is tamoxifen, and actually branded tamoxifen, I gather, can be much better. Again, I'm sure you know this, than some of the generic ones, which is quite interesting. So I often say to patients to, work out which one they like, and then use that. And then you've got the chilly pillows and the fans and all those sorts of things, avoiding alcohol. But there are other sort of non-hormonal things that you can use. We quite often use some of the antidepressants, SSRIs, things like that. Also, there's something called venlafaxine and gabapentin. So there are a lot of other options. They don't have any of the lovely benefits from your bones and your cardiovascular system, but they can just help you feel a little bit better. And if you're on tamoxifen, you can use vaginal estrogen. If you're on letrozole and aromatase inhibitors, then you're not supposed to, although I have been involved in people who have in the past with oncologists' approval. And I think it does depend on how your oncologist is as well, and also how you feel. And I think individual patients have to take their work out what's important and how they feel. And I listened to a really interesting podcast the other day by another menopause doctor who herself has had breast cancer twice, in fact, and has continued to take HRT. And she said every patient should ask their oncologist exactly what the numbers are. So when they're being treated, what number is it, by how many people are going to be protected if they take this. And I think it's really, really interesting way of thinking about it, because we always talk about percentage reduction for this, that and the other, and actually numbers it makes it much more clear. So I think there's probably going to be more and more HRT being used because there's so much breast cancer around, and because I think people are being much more aware of their health, especially with things like Davina and all these other podcasts around. So that, and vaginal moisturizers and things like that, of course, I've forgotten about those. If you can't take estrogen and stuff, then you can use, even if you don't want to take estrogen, you can use vaginal moisturizers, things like Yes and Replens is not quite as good as Yes, but you can use that I went to a talk a while ago, and they were saying that women spend a fortune on facial moisturizers, but they never think about their vaginas. So we should all be doing that apparently as well, if we needed to. So okay, I think I might stop there if that's all right. Sorry, I've rambled on through. I hope I've covered most things that as an initial bit, but have we got any questions yet? I hope I can answer them.
So Victoria sent a couple of questions over to me as well, a little bit earlier on today, which I think some of them are fantastic. So it's probably worth going through those. And do, as Aga said, and Victoria, feel free to pop your questions in the chat as well. So we have first question. So if my symptoms are not too bad and I'm managing, should I still consider HRT for the long-term benefits?
Well, that is the difficult question. I mean, nice guidance who we all follow says you should only be on HRT for symptom control. You shouldn't use it for long-term health benefits. But I think if you speak to most menopause doctors, including myself, you will find that most people are on HRT and actually probably do, well, of a certain age, obviously, and for the benefits. I mean, you've got to, as I said, you've got to look at your family history. I didn't really talk about that actually, but if you've got a strong family history of breast cancer particularly, there's so much more genetic mapping and screening now, and actually if you have a chat and you still want to take it, if you have a bad genetic, if you have a slightly riskier genetic profile, then you basically your risk is going to be higher than somebody who has no family history. I mean, I'm not just talking about one case, I'm talking about several. But if you have a bit of breast cancer in the family, your background risk is probably, even if you're the BRCA gene negative, there are a lot of other genes coming out now as well, but your risk will be a bit higher than anybody. But having HRT on top of that doesn't multiply the risk. It's just an extra risk. So it's on top of your own risk. So a lot of people who feel so terrible just take that risk. And I think from the breast cancer point of view, again, the latest evidence that came out in October, although the study was massively flawed, but anyway, it says that the longer you're on HRT for, probably the more the risk builds up. But I think most people, and certainly NICE would say that for 5 years, you're not going to do yourself any harm at all. And as I said, I've got loads of people in their 70s who are very happy on their HRT and have no intention of coming off, and I have no intention of stopping them unless something changes and they have a reason to. So consider it, I guess.
Yeah. So my last period was 8 years ago. Is it too late for me to start HRT? I'm no longer having any symptoms.
No, it's not. I mean, I think if you haven't got any symptoms, I'm involved in quite a lot of chat groups at the moment, and because obviously of Davina and the prevention and everything, there are a lot of older ladies coming through without symptoms, and I think that's again quite a difficult chat to have, because according to the guidance you're not supposed to, but I think if you've got symptoms, I have absolutely no qualms whatsoever of starting people on. In fact, I did yesterday somebody who I think was nearly 20 years after the menopause, and she absolutely swore blind that she had been feeling horrendous all the way along, and in fact had been recommended by another of my patients, and it wasn't a new thing, and I don't think there was anything else going on. And so we've just started really, really low and really, really slow and just take it up from there. And as I said, if it's transdermal estrogen, the main problem about being older is that your risk of getting things is higher because you're older. So you're more likely to have a heart attack, you're more likely to have a stroke, you're more likely to have a blood clot, you're more likely to get breast cancer, all those sorts of things. So actually, if you have a big gap, then your risk, and then you start HRT later, then that's the problem. Your arteries can start to flare up and things. But if you start it with transdermal estrogen, there's a very low risk of that happening, and there's no increased risk of thrombosis with transdermal estrogen. So if you are older and haven't got any other risk factors, again, it's a discussion to be had. It's not like, yes, of course you can have it, but it's certainly not a definitely no, you can't have it without further chat, really. So yeah.
Fantastic. So I have the coil and did use estrogel for a little while, but have stopped. Would you advise using that again?
If you've got symptoms, yeah, absolutely. If your coil will last for 5 years for the menopause or for endometrial protection, and much the same actually for contraception. And that's because I didn't talk about contraception, so that's something else. So yes, absolutely. If you've got your coil, it's in date, and you've got symptoms, crack on with your estrogel again. No reason not to at all, because you're protecting your womb, as long as your blood pressure and all those things are all, you know, otherwise fit and well and healthy. But contraception around the menopause can be a bit tricky, because obviously your periods are becoming erratic, and if you are more than a year after your last period, you can go on to continuous HRT, which I didn't talk about, sorry, which is basically when you have estrogen and progesterone every day, and you don't have any periods. If you are still within a year of your last period, then you have to go on what's called sequential HRT, where you have estrogen every day and progesterone for about 2 weeks, unless you have a Mirena coil. And at that point, you're still fertile. So while you're still having periods, if you're under 50, you need to have 2 years from your last period before you can stop using contraception. And if you're over 50, a year since your last period before you can stop using contraception. Of course, the difficulty comes if you then start using HRT when your periods haven't finished, and then at what point you have to stop contraception. So generally they say 55 if you are not sure where you are in your, you know, with periods and things. But that's why the Mirena is so nice, because obviously it does contraception and it does HRT. Did that answer that?
So, I'm sure it did. I've been on Femiston for a year. Should I remain on the same HRT?
Should I what? Sorry, say again. Been on Femiston
for a year. Should you remain on the same HRT for the duration of your perimenopause?
If it suits you and you've got no other risk factors, being on Femiston's fine. Obviously, that's a tablet. So if you had any, if you were overweight or have blood pressure or have a history of migraines and things like that, then you might be better on a transdermal one, a patch or a gel. And certainly if you're over 60, then I would change everybody onto a gel, and or at least have a serious discussion about why they wouldn't want to be on a gel or a patch at that point. So there's no need to change if you're happy, but if unless you haven't got any risk factors. But sometimes people obviously are started on tablets and things by, and I don't mean it rudely because I'm a GP, GPs are fantastic and do lots of stuff, and you can't be an expert in everything, but you know, generally now the move is for transdermal estrogen first line, and then, but some people don't get on with it for various reasons. So you know, it doesn't suit everybody, and you know, generally HRT is quite straightforward, but often people struggle to find things to suit them, and that's when you have to tweak around a little bit more. And you vary doses. There's lots of different types and pills and potions, but the basics are the same. But some people really struggle with something called progesterone intolerance, which is where you just feel lousy when you're taking the progesterone bit, often quite moody and things, and it's usually quite obvious when they've got that. So then there's a bit more fiddling around of preparations that can be hard. There's ways of getting around it, but it's a bit more of a fiddle. And the other big problem is irregular bleeding, and that's the thing I find most frustrating actually, because if you're having bleeding irregularly on the HRT, it's fine to start with when you're fiddling around and starting doses and getting sorted. But if it goes on, then you start having to have scans and some investigations and things. But again, that's why the coil is lovely, because generally on the coil that doesn't happen. But you can change your progesterone and things like that to reduce all these things, but that's when it becomes a little bit more complicated. So that's probably when I tend to see more people, I think.
Yeah. So sorry, my computer seems to be echoing. So I fall asleep, foggy brain. I don't know if maybe Aga and Alex, just whilst I'm asking the questions, if you guys want to mute. I don't know if that might.
Let me just Katie, I muted you now. Is that still no?
Yeah, that seems to be good. So if I've got poor sleep and foggy brain, did have regular periods, but I think they've now completely stopped for the last 3 months. Have been to the GP, but they've not recommended HRT. Would you recommend just starting, or would you actually waiting until
No, start. If you're am I on? I'm on, yes. If you're symptomatic now, yeah, absolutely start. You can still have really horrendous sort of menopausal symptoms and be having often a reasonably normal cycle. I mean, usually you start to skip a period here and there, but yeah, if you're in any way having an erratic cycle, I didn't even mention periods, did I, at the beginning? I'm sorry. That's one of the biggest obvious symptoms of the menopause, is that your periods become very irregular, whether they're more frequent or less frequent, but usually less frequent. And there's no kind of one size fits all with the menopause. It's a little bit like pregnancy. Every woman's different and every pregnancy is different. But some people just, their period stops and they never have another one again. Other people start missing them. Other people get more frequent and then have a gap, and then you can have a spell of 6 to 7, 9, 10 months, and then you're thinking it's all over, and suddenly that one throws in. So yes, absolutely. Just if you're symptomatic, having irregular periods, and you want to go on HRT, go back and speak to your GP and ask, because they might not, not everybody's. I mean, I literally live, sleep and breathe the menopause and HRT at the moment. So, everybody I see pretty much as a female of a certain age is going to get offered it or mentioned it. But it's not in the forefront of a lot of GPs, minds. So you can sometimes give them a bit of a nudge.
Does HRT, oh, sorry, Alex. Sorry, everyone. So does HRT increase the risk of other cancers aside from breast cancer?
No, not particularly. I mean, there's possibility with ovarian cancer, but I don't think, again, that there's not good evidence for it. Endometrial cancer, if you're not using progesterone properly, yes, definitely does. But I don't think there's any other really that are associated. And even most of the gynae cancers that women get. I was just having a quick double check before I came on, since I'm in obviously a cancer specialist group. But actually, having the current guidelines in pretty much every cancer, that you can use HRT after treatment. You have to be careful about adenocarcinomas of the cervix, and obviously breast cancer is a discussion to be had, but generally ovarian and endometrial, vulval, vaginal cancers are mostly fine. So, and yeah. So I don't think so.
So I think this is a fantastic question, actually. Why doesn't the NHS have a defined screening or information program for the menopause, considering half of the population are going to go through the menopause?
I don't know. It's a very good question, which we, menopause specialists and interests are going on about a lot. And I think personally, because they can't afford for us all to be on HRT, because it's too expensive if half the population are on it. Well, not half, but half the population of a certain age are on it. But yeah, I don't know is the answer. I think it is coming. I think it is getting better. Obviously things are horrendous at the moment with COVID and everything, and GPs are really struggling, and I know it sounds like we're making excuses, but practices are overwhelmed. They get so many more patients coming in than we were pre-COVID. So I think that's probably one thing. They're not going to be starting to encourage people to come forward, which is silly really, because actually at the end of the day it has got such good prevention. And I don't know how, when you're out and about, to see how many crumbly old ladies you see. I mean, my mum shrunk by about 5 inches, I think. She's half the size she used to be, and she was pretty small to start with, and purely because of osteoporosis. And she was on HRT, and then one of the big scares came out, and she's never forgiven me for telling her she should come off it. But changed my tune now. Oh gosh, the questions are still coming on. I can see that. I can see that one about rheumatoid arthritis. I mean, again, the same transdermal. Always, I always go everybody will start off on transdermal unless there's a specific reason for them not to want to take it. You know, if you've got horrendous skin rashes and stuff, but I would usually start you on it as an offering. And if you didn't have any risk factors, then, you know, I'm happy for you to try oral estrogen and stuff like that. But at the end of the day, transdermal is all the way. Didn't see any other questions.
So I'm on a patch and have been for a few years. All my symptoms have disappeared, but now I'm starting to notice the symptoms coming back. Would I increase the dose, speak to my GP to do so?
Yeah, I mean, ultimately, it depends what sort of dose of patch you're on. But yes, it sounds like you need more, and your symptoms can fluctuate, and you can be quite happy stabilized on a dose for a while, and then suddenly you need more. So yeah, I mean, that's when you definitely just try a higher, you know, I'll speak to your GP, because you shouldn't really do things without talking to them. But generally, yeah, increase the dose. And the point at which I start doing more blood tests is when you're on the maximum sort of supposed dose of the maximum patch is 100 that you can get. So if you're not feeling better on that level, then it is worth checking your estrogen levels to make sure that you're actually absorbing it properly, because some people don't absorb the gel and the estrogen from the gel or the patch, and so you need higher doses. Doesn't mean it's not working, it just means higher. So
yeah. So if your mum, for instance, got breast cancer post-menopausal, are you at higher risk?
Probably. I mean, I think it's difficult. It's not in quite the same way. I'm not in any way a genetic expert. There are loads of algorithms and charts and forms that you can fill in, and probably one postmenopausal breast cancer in the family, I don't think particularly increases your risk. But I think if you have more than one, particularly obviously premenopausal one, I think there is, and there's so much screening now, and all the breast cancers are checked. The actual cancers themselves have their genetic testing done on them now, and depending on what's found, lots of people are invited for, you know, screening and family screening and stuff. So probably one on its own, I think, no, not necessarily. Stop there.
So are things like low B vitamin, vitamin B12 and vitamin D related to the menopause, or is it just a coincidence that this kind of all happening at the same time?
I think most people in this country are low in vitamin D, certainly in the winter. I actually hardly ever check them because I've never found a normal one. And the guidance is that we should all be taking vitamin D in the winter. In fact, I was speaking to somebody recently, a friend of mine who's orthopedic consultant, had said we should all be taking vitamin D all year round, because if we only take it in the winter, we'll forget to restart again after the summer. So I think it's coincidental. I don't think there's any, it's not a relation, but you know, it does help. Does my practice offer the pre-treatment? I've just seen that one, but pre-treatment blood, I mean, if people want to have blood tests done, absolutely fine. We're very happy to do them. Of course, it's not a problem at all. But the only time I absolutely always do blood pre-treatment is with measuring testosterone levels, and that's just before you start it. It's not that you're expecting them to be high, because they're generally very low, but you want to make sure that there's nothing else going on that has caused an artificially high testosterone, because when you check it in 2 weeks time, you need to know that it's the 2 months time, sorry, you want to make sure that it's what it was before you started. But yeah, we very happy to do any bloods if people want to, and it is quite interesting to find out what your blood levels are before you start. I think you know, it doesn't, if you're still having cycles though, you're still having periods and things like that, one blood test can be very different on one day, and even the next day it can be you know, totally different. So it's not always helpful. Postmenopausal, you know, it's generally, if it's low, it's low, but before your sort of finished periods, it can fluctuate a lot.
So I can't take HRT as I've recently had hormone sensitive breast cancer diagnosis. Could I take testosterone on its own?
Again, you're not supposed to have testosterone, because testosterone converts to estrogen. So it's not advisable in the same way that you wouldn't use estrogen generally. There is a new testosterone-based gel for vaginal dryness, that again you could discuss with your consultant and weigh up pros and cons, but it is testosterone based and it is absorbed locally. It depends what other treatment you're on, but that's occasionally a possibility. We have used that.
Fantastic.
Again, with caution.
Does anybody else have any other questions at all? Or Aga, Victoria, you want to add anything?
Well, I'm sorry if it was a bit rambled. As I said, it generally is informal. I try not to follow. I don't like making speeches as such, so it has to be a bit ad hoc. But hopefully, there was something that useful for people in there.
I think that's been really, really great and really helpful. And I think just from me now getting quite vocal about it and talking to everyone, that you've sort of answered a lot of the questions that people often mention. I mean, most people, the conversations I've had, it's been breast cancer that's been the main worry. And the other thing I'd like to say is that I would have said before I started HRT, I would have said that I felt fine, that I didn't have any symptoms, but I feel 1,000,000 times better. My work's better, my home's better. I feel happier. I don't ache. I don't, stagger out of bed in the morning. So I think that you don't necessarily have to have symptoms that are so bad that you can't cope with them anymore. It's you just kind of forget what you were like before until you feel better again.
Yes, absolutely. I think that's very true. And it's amazing how many people come, and we have a questionnaire that we get people to fill in, and they said, oh, I didn't really think I was that bad, but I've ticked so many of these boxes. I had no idea that, until you actually have it in front of you, you don't really realize. So
No.
I agree with that. Yeah. Good.
Brilliant, thank you
so much. That's absolutely amazing session. We've got some comments already saying how informative that was and how helpful that was, and I'm sure just this is an opening to a much bigger and longer conversation around menopause in our trust amongst the women and men as well. I think we need to really engage with the men about it as well. So we are very, very grateful, all of us, for your time, guys, and very grateful for your kind offer coming here and talking to us. And if anyone wants a little bit more information or anything else from those lovely two ladies, the Surrey Park Clinic is open to us, and the link is in the comments already. Katie kindly put it in there. So I'm going to stop recording now.